The patient that has failed hydroxyurea has many potential different paths to get to that clinical determination. Indeed, an inadequate response to hydroxyurea, I think, is a clinical observation that can be on the basis of resistance, intolerance, or both. Resistance really being having an inadequate control of the disease at the dose they tolerate. Is that inadequate control mean that the spleen is too large, they have too much in the way of symptoms, they're having vascular events, or the counts aren't controlled? Or are they really intolerant, where at the dose that controls the counts, they either have the development of neutropenia or thrombocytopenia, do they have GI toxicities, do they have cutaneous toxicities such as recurrent skin cancers, mucosal ulcers, leg ulcers. So it is really a balance. Some patients really will have some components of both. They both have some aspects of resistance or intolerance, and we need to factor all of these considerations as we determine, are they really having a good response to hydroxyurea, or do we need to consider a second-line therapy?
Polycythemia vera patients that are treated with hydroxyurea can benefit from that medication for a long period of time. But the medication needs to control not just the red blood cells, but also platelets, white cells, symptoms, and the spleen. This is what we would like to achieve in every patient, to look at the person, not just at the blood count. About 20 to 25% of patients on hydroxyurea do not do well. They do not achieve a goal of control of the blood cell count, symptoms, and the spleen. In that case, we look for other options. Not too long ago, there was a significant development in polycythemia vera with approval of ruxolitinib, a JAK inhibitor, as a second-line therapy in patients that are intolerant, refractory, or are progressing on hydroxyurea. And now ruxolitinib is a full-fledged option which can provide benefits again for these patients in controlling the red blood cells, white cells, platelets, spleen, and symptoms.
The approval of ruxolitinib in polycythemia vera has been very impactful. First, it's actually the only approved therapy for polycythemia vera. Hydroxyurea, although used as a frontline cytoreductive therapy, is really on a historical context. It's not actually approved for that indication, but certainly is used as a historical drug in that setting. So it was very impactful in terms of bringing a lot of both consideration, science, and thoughtfulness in terms of how are we managing these patients. Now, the availability of ruxolitinib for these patients has been very impactful. And as we look at the phase 3 study, the response study that led to the approval of ruxolitinib, it helps to highlight the benefits of the therapy. Specifically, first with control of the counts, control of erythrocytosis, helping make patients that had already failed hydroxyurea, helps control the counts with no longer them needing phlebotomy, control of leukocytosis, control of thrombocytosis. Next, it's helpful in terms of controlling splenomegaly if present. Third, improving symptoms. So if they have difficult symptoms, particularly some things that really respond to very little else in these patients, pruritus, night sweats, fatigue, it can respond well. And finally, a key goal is to decrease that risk of thrombosis or bleeding. And compared to the control arm, patients with ruxolitinib seem to have a very significant decrease in that risk of vascular events. And that might be multifactorial. It might be improvement in those counts, but it may also be regarding improvement in the inflammatory milieu that these patients face, that those inflammatory markers may be somewhat contributory toward the risk of thrombosis.
While hydroxyurea is an established first-line therapy for patients with polycythemia vera that need cytoreductive therapy, not everybody benefits. So in patients that are intolerant or resistant to hydroxyurea, we need new therapies. And ruxolitinib was recently approved based on a so-called response study. So patients that were previously treated with hydroxyurea, not doing well, not responding, or intolerant to it. Intolerance is sometimes seen as a skin ulcers or mouth ulcers or low-grade fever or hair loss. These are all possibilities that are not related to its effect on the bone marrow. These type of patients were then randomized to receive a new medication at the time, ruxolitinib, now approved. So ruxolitinib one arm, best available therapy the other arm. Patients were monitored for improvements in the red blood cells and the spleen, because patients in this study were mandatory to have a big spleen. But also, as a second goal, there was the control of red blood cells, white cells, spleen, symptoms, all together. 5 factors were monitored together. So this is complete hematological response, including the symptoms and the spleen. And this was achieved significantly in a number of patients on ruxolitinib versus best available therapy. This led to approval of ruxolitinib as a second-line choice.